This is Hadi Lichaa, interventional cardiovascular specialist, addressing briefly the topic of alternative arterial access in the treatment of critical limb ischemia.
Basically, I thought I would access this topic by asking four questions. What is alternative arterial access in CLI? Why do we need it? Where are the access sites? And who are the patients that we need to select versus not? Let's start with what? What is alternative access site? Basically, the fair definition of that is everything that's except retrograde common femoral artery access that all of us are accustomed to. So all the access sites and directions are considered alternative access sites. Why do we need it? There are a lot of reasons why we need it, and I'll start with this. Basically, there is all of us have dealt with hostile groins. Hostile groins are include previous cut downs, fungal dermatitis, cellulitis, large pannus, recent groin complications, and on the other end of the spectrum, extremely thin patients, which are also predisposed for complications. So that also brings up the opportunity to access other sites besides the groin. The other thing is the iliac tortuosity and calcifications cause a lot of pushability and torqueability issues, as well as increase the potential for dissection and perforation in anatomies like that where we have to go up and over. The other aspect is the amount of force that is transmitted through tortuosity is significantly dampened by all these vectors of friction encountered in iliac tortuosity instead of going straight antegrade access from the common femoral artery. Other contraindications include osteal common iliac artery stents, where not only we would deform the stents, but we cannot deliver equipment even if one attempts at. Aortobifemoral bypass is also another situation where it is not recommended to go up and over previous endovascular aortic repair situations. And all our CLI practices have a lot of these patients, long 40 centimeter CTOs, heavily calcified, multiple in-stent occlusions that usually require a lot of force, a lot of torqueability, and a lot of pushability, which is not really optimal with the up and over approach. Another aspect is also the convexity and concavity of the proximal and distal caps, which has to be taken into account in the selection of arterial access in a CLI case and will definitely affect success rate. And this is a CTOP classification that classifies that from 1 to 4, depending on the convexity and concavity of proximal and distal caps. And we take that into consideration in a lot of cases. The other aspect is in tibial interventions, there are no dedicated re-entry devices. So we have often to use cart techniques, reverse cart techniques that have been developed in the coronary CTO world, which require pedal access. The other aspect is the epidemic of diabetes and end-stage renal disease, which affects a lot of infrapopliteal vessels. We often see non-occlusive disease in the SFA and the iliacs and triple vessel occlusive disease infrapopliteal segments, which require a direct access either from an antegrade common femoral or retrograde tibial for the reasons of distance, pushability, crossing, torqueability, and friction. The other aspect is the radial to peripheral movement, which is very optimal for visceral interventions and renal interventions. And often, this is the case of an SMA, a stenosis that was accessed from a radial approach, given the optimal angle of takeoff and the ability to deliver equipment without struggling from the groin. Of course, there are also patient benefits for the alternative access with much less complications, early discharge within 1 to 2 hours if you consider the radial and the pedal access sites, instead of the large groins that we have to deal with and predispose for a lot of more procedural morbidity. The other aspect that's favorable for patients is patients with back pain, intractable back pain, and cannot tolerate that. So pedal access by itself is a huge advantage, and it has the advantage of decreased radiation exposure to the patient and the operator and decreased contrast use. Now, where are these access sites? This figure shows the possibility of access sites. Almost every part of the arterial segment anatomy is possible, with pros and with advantages and disadvantages, including extra anatomical bypass grafts. Obviously, when we say alternative arterial access, people think it's only tibio-pedal, but it can involve the upper extremities and the lower extremities. I picked a few examples just to show the most frequent use. An integrated superficial femoral artery access has been one of my favorites. It obviously has a higher potential for bleeding and non-compressibility compared to the common, but much easier done under ultrasound. And even there are a lot of series that show safety of closure of the superficial femoral artery itself. And there are obviously risks and benefits that have to be weighed with every case, the lowest sheath profile. Distal retrograde superficial femoral artery access can be an option in thin patients, especially when we're struggling from above and there are no options from pedal access. So this is a case where we were able to successfully fix the problem with a sheathless approach and then followed by angioplasty of the access site to prevent extravasation. The other access is a stent. A previous occluded stent is also an easy target for us. There are multiple techniques that allow us to cross this retrograde instead of sticking the foot, and it doesn't really have that much morbidity if done correctly. Another aspect is an antegrade tibial access, not retrograde, which adds a lot of support for below the ankle interventions. This is a case of a plantar digital access when we were not able to re-enter in below the ankle, and digital access with calcified arteries is a big advantage in this case, and especially in the sheathless technique. The radial to peripheral movement has taken off, and there's a dedicated series of equipment that has pros and cons, but the major advantage is the patient morbidity, the decreased vascular complication, and early discharge. Of course, we're not going to pick that for iliac occlusion since the support is suboptimal. The combination of radial to peripheral with pedal access is optimal. Diagnostic from above and interventions from below, and that has been a technique that we have picked. Axillary access has picked up in the structural world interventions and mechanical circulatory support and is now preferred over brachial access given the to control bleeding, and is usually picked for aortoiliac interventions. This is a figure that shows the complication risk going from radial to brachial and all the access sites in between, and this is of course to be taken into account whenever we plan a case. The access sites also include extra anatomical bypass grafts, like in this case where an AXFEM bypass was picked for an intervention. It is doable. And finally, who to pick for alternative access? Basically, we have to be careful. There's no free lunch. There are multiple very well documented complications, including dissection, thrombosis, hematoma, compartment syndrome related to continuous extravasation from tibiopedal access site, pseudoaneurysms, AV fistulas, infection. So people think it's easy, it's fast, people go home. But we have to be very careful. We have to pick the highest risk patient populations if everything else fails. We don't want to burn bridges. Any possible bypass target for the surgeons is absolutely not to be stuck. Remember, the morbidity is all about hemostasis in these kinds of procedures. And please do not pick upper extremity access in type 3 arches, especially the right radial, when you're planning a peripheral access. And finally, I would just say for optimal success in critical limb ischemia interventions, one must be familiar with a lot of tools and a lot of access sites in order to be successful.